Hi, and welcome to the next episode of Lessons from the Lab. I'm Devin Rubin from Mayo Clinic in Jacksonville, Florida. And for this episode, I have a bit of a surprise for our guest. We're going to see if he takes the bait on what I'm going to present him. This is a very experienced electromyographer. It's someone who is experienced not only in performing the studies, but in evaluating other studies, dealing with fraudulent studies. And I'm going to present a common patient problem that we encounter to him. I'm going to give him some data that is somewhat false data and see what he thinks about it before we discuss the actual approach to this patient. So a little bit of tricky here, but I think we're all going to learn something. I think we're probably going to learn quite a bit from our guest. So I hope you enjoy. Well, welcome to this episode of Lessons from the Lab. I'm Devin Rubin, and I have been excited for a while now for our guest, Dr. Peter Grant. Hi, Peter.
Hey, Devin, good to see you. Thanks for
Hey.
having me on.
Oh, thanks for coming. Dr. Grant is someone I've been trying to have on for a little while, and we finally found a time to tape. So I've been looking forward to this all week. Dr. Grant is a physiatrist in Oregon. He's a past president of ANEM, past chair of ABEM. He's a EDX fraud expert. He's an adjunct assistant professor at The Ohio State University, if I said that right. And he's
Yeah.
an all-around fantastic guy, and that's the most important thing. So it's a pleasure to have you, Peter.
Thank you. Thank you. And all of that is back at you too, Devin. You're somebody that I've always looked up to and appreciate, especially at the meetings. Some of the talks you give, I enjoy going to. Even having done this for 42 years, I still learn something from you. So I love that.
Well, I learned from you, and I'm sure I'll learn from you today. And I've learned a lot today already. That our time difference makes it hard. I don't know. Have you been doing EMGs today?
I
Or are
did. I
you?
did a half day. I did 5 in the morning and then I had a quick lunch and then we're on now.
Yeah, yeah. This is the end of our day, of course, here, and it was a busy day, but lots of, I always am just amazed every day. There's so many interesting patients, and even the things that are common end up being interesting.
Oh, they
So
can. You're exactly right. Yep.
that's why we do it for 42 plus years. I still have a ways to go to catch up to you, but
You'll get there.
so yeah. So anyway, the intent of this is to teach whoever's watching or listening on podcast how we might approach patients in the EMG laboratory. And I like to present a case to you and kind of pick your brain, and we can discuss the case a little bit and how we might each approach the patient from an EMG standpoint.
Sure.
So is that okay? You ready?
Sounds like fun.
Okay, so the patient I want to present is a patient we had in the lab a couple months ago. He was a 58-year-old man who was referred for evaluations of some numbness and tingling in his toes. And he basically had it was about a year history of some lack of sensation, a little bit of tingling and burning sensation in all the toes of both of his feet symmetrically. Over the course of over the year, it kind of progressed to about the balls of his feet. He walked around like he had kind of socks bunched under his toes. He
Right.
had a little bit of tingling and kind of pins and needles feeling in all of his fingers as well, but just the fingertips.
Okay.
And really that was it. He had a little bit of imbalance because of the feeling when he stood in the shower and closed his eyes. He was a little bit off balance. He didn't have any weakness, and his medical history was notable for borderline diabetes, but otherwise a healthy guy.
Okay.
And on his exam, um, he had reduced his absent Achilles reflexes. He had normal strength, and he had a gradient of sensation really to all modalities, pinprick vibration and slight joint position to about his midfoot bilaterally. But otherwise, his exam was normal. So
Sounds.
you ever see a patient like that?
I got to tell you, I see. We all see those patients all the time,
Yeah.
and what's interesting is they are there to be found It's whether we pick up on it, because what you just described sometimes is their primary symptoms, and other times you're seeing them for something else, maybe even in the arms or neck or head. And if you ask, or if they mention and follow up on it, they have that same story. So it's out there a lot. We just have to follow up on it. Yep.
Yeah, yeah. So no surprise, I guess, but if you were seeing this patient, what localization or diagnosis are you thinking this patient has?
Obviously, the first one you think of is a generalized peripheral neuropathy. I mean, he has just the classic. In fact, one of the things you said, I want to point out, it is so common that if they don't mention it, I always ask for it. And that is feeling like you're walking on a wadded up sock. And they have different ways. I'm walking on cork. I have saran wrap over the bottom of my foot. All these different things that describe this sort of weird sensation. In addition to the more common things you mentioned, numbness, tingling, maybe some cramping or burning in the feet too. But that weird one, that walking on a wadded up sock, is most of the patients will have that if you ask them about it, some form of that. And I've always found that very interesting. It's such an interesting complaint.
Have you ever wadded up your sock and put it in your shoe and walked around with it?
I
Wadded up?
haven't, but what's interesting is I probably have, this is maybe telling you too much of my medical history. I probably have a very early neuropathy that was unmasked for a little while after a spinal surgery I had. I just had a foraminotomy. It was not a big deal. Did it on Friday morning, back at work on Monday. If I had to do it again, I'd probably be back on work on Wednesday. I came back a little soon, but it was a minor procedure. But I had a bit of a complication afterwards where I had sort of an arachnoiditis, or an inflammatory response that heightened my symptoms for about a week, and then I got better. And that was 7, 8 years ago. I play tennis every morning now. I'm doing fine with my back. But that was weird was I had during that week when things were aggravated, I had every time I got up, I either felt like there was a hot bar pressing on the ball of my foot, or that feeling of something was just there. And I reflexively would go down and like feel for it, and it wasn't anything. So I do know, I think what they're talking about. I have a feeling 15, 20 years from now, I'm probably going to, get a neuropathy. And that was the first thing, first inkling of it, in that compromised sort of way postoperatively. But yeah, it's an interesting sort of sensation to feel like you've got something under your foot, and yet there's
Yeah.
nothing.
I think, since we're sharing medical problems for this, which is what I'm sure the listeners really want to hear, our medical problems, but I think it is good. I hear this all the time. I see tons of patients with neuropathy and I shake my head and say, yeah, I know what you mean. I know what you mean. I know what you mean, but I don't really, right?
Mm,
Because, I know because all the patients say this. So I think it's always good. Not that I want to experience the symptoms that the patients have, but I have experienced, and I actually am neuralgia paresthetica,
oh,
because
okay.
and you always think, and this is sort of an aside, but everyone says, oh, that's because people gain weight, they wear tight belts. But my wife and I are training for a big hike. So we've been using our backpack and it's tight around the hip and doing a
Yeah,
lot of walking. And this has happened to me before. And then after training and kind of stretching that nerve or whatever I'm doing, I'll get those electrical shocks through the day right in that distribution. And it's fine. Like I can deal with it, but I think now I know what some of the patients are
right.
experience. You feel it, and now you can really say, yes, I understand to some degree what you experience. So
Exactly. That's interesting. That's interesting.
yeah. So anyway, okay, so let's go back to not our case as us, but this patient. So
Uh-huh.
if so, I guess the first question for you is, with that story, do you think this patient actually needs an EMG test? Like,
Oh, I do. I do. Yeah, I think that there are other mimics, and I think that it, just by frequency of what we see, by the odds, so to speak, from as much as you did tell me about his physical examination and history of symptoms, I definitely think that you're gonna probably end up with that. But there are other things that can even begin more like that, or other things that can be that we just need to know for sure, especially if we're going to talk about some form of treatment. If his sounds bad enough that he probably would want some form of, low dose, uh, 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 um, like Neurontin or Lyrica or Cymbalta or something to help out with that. But I think we need to confirm that diagnosis before we enter into any treatment, especially
Mhm.
pharmacologic, where there may be some side effects and such.
Yeah. And I would agree. I mean, I think this is it, you've heard and we've all heard the debate if he's borderline diabetic, but if he's had longstanding diabetes, it looks like a duck, it smells like a duck. This is a diabetic duck, diabetic
Right.
neuropathy
Right.
that maybe you don't, but if it's borderline and as you said, I think we've all probably seen patients that have L5 and S1 radiculopathies that cause numbness in the feet. And so there's a value in excluding that as a cause too, I think. So,
Sure. I
yeah.
agree.
Yeah. So, okay. So what I like to do when I have done these is I like to ask the guest how you would approach the patient, but I'm going to do something different with you. I'm going
Uh-oh.
to show you the conduction studies that we did and see how you would interpret this here. So,
Sure.
I'm going to share my screen here and hopefully you can see this. And I'm just for the people who can't, can you see the slide
Yeah,
a
I
little
can.
bit? Okay, so I'm going to
Yeah,
just
I'll watch it
summarize
for you.
this for people
Sure.
who aren't watching and are listening on podcasts. So this is a table of the conduction studies that we did. It's and so we did the left fibular and tibial motor which showed a mildly slowed velocity of 38 and 37 meters per second. The left Searle, and he's 58, had an amplitude of 5 and a slightly slowed velocity of 38. The medial and lateral plantar were 3 and 2 microvolts. And then we did the same nerves on the right, got the same mild slowing of conduction velocity in the fibular and tibial. The Searle was about the same. The plantars were about the same. And then
Okay.
we went up to the arm and we did the median and ulnar motor studies bilaterally, which were normal. We did the median and ulnar antidromic studies bilaterally, which were normal. And then, his fingers tips were mainly the numbness, but I think for some reason we did the lateral and medial antebrachials bilaterally and they were normal. So all normal in the upper extremities.
Okay.
So what do you think about this?
Well, the first thing I'm going to say is that labs are different, and everybody needs to understand that. Some of the numbers you have, I would have called borderline or abnormal, like 2.5 millivolt, perineal fibular amplitude. I know perineal is usually less than tibial anyway, but even the tibial, I like to use 6, and so 4.9 would be a little low for me too. So I think we're definitely talking about some axonal involvement here, especially if I'm using my values. I would say it's definitely axonal. And in fact, what we see as far as slowing, I like to use 40. And so, yeah, they are slowed, but again, they're minimally slowed. I could almost say this is axonal, but you have some slowing because of some loss of some of your faster axons. And that I wouldn't be inclined to jump on the boat and say this has to be demyelinating. I think these numbers are enough that you could almost make a case for both. But I just know that again by the odds, axonal neuropathies are much more common than demyelinating. And I think I look at this, and the first thing I want to see, not only the ones that you have highlighted in red, but some of the ones that in my lab I think I would count as small too, and I would be more impressed with the axonal involvement than demyelinating. Of course, you're now going to tell me this patient had a demyelinating neuropathy, and and I'm way
No,
off base to say all
no,
those
I'm
things.
not. I'm not. No, this is like, but I am gonna ask you something different.
Sure.
Do you think we did enough nerve conduction studies in this patient? So
Well,
we did for this problem, we did
yeah.
22 nerve conduction studies, the same
Well,
studies bilaterally. And
yeah.
I'm
That's
not,
a lot.
I don't want to put you on the spot
Oh
because
no.
this is not what we did. So,
Okay.
this is a little bit of a trick, but that gets to the question
Yeah.
of, is this too much if someone did this, is this too much or is this appropriate for this patient's clinical problem?
Yeah, honestly, I think, especially when you're talking about the medial and lateral plantars and the antebrachials, I surely don't do those as regular. So that takes away eight right there. I surely don't do those. As an aside, I want to mention that most of the time when I see a patient that comes in presenting with, numbness and tingling in their feet and toes, and they tell me about any hand involvement, most of the time it's a secondary carpal tunnel syndrome in the hands, not actual generalized peripheral neuropathic disease in their hands and fingers. I think that you have to be a certain distance down the road in severity with your generalized neuropathy before you get it in the hands. And I see most of the people before that, but if they do have numbness in their hands. So what I'm getting at is I probably would have done some of the upper extremity studies like you did there, thinking of a carpal tunnel. And I think a lot of the time you do end up finding some component of carpal tunnel. In this patient, we still had to evaluate the hands. But I think that I do agree with you that 22 is a lot. And I don't do that many normally,
Yeah.
even if I'm doing upper.
Yeah, I like the lateral and medial antebrachials. And the reason I'm asking you this and showing you this, of course, because you've done so much work over the years on fraud and excess and appropriateness of EMG so I think this raises an important point. And how much do you have to do? And is there guidance on how much you do in someone with, say, a suspected distal neuropathy?
Sure. And a quick overview of what I like to do in the legs and feet in somebody that comes in and has symptoms of what I think is a neuropathy. I will do perineal sensory one side, or fibular sensory. I will do perineal fibular motor on one side. I'll do tibial on that side, and I usually sneak over and do the other side. I want to make sure that there's some involvement in both lower extremities. I actually, believe it or not, like H-reflexes. We can go over that at length, and I can give you the pros and cons, but it's not a very specific finding, but it's pretty sensitive, meaning most people that have any decent neuropathy are going to have a slowing or absence of an H-reflex. And I know that's a little controversial, but I'll do an H-reflex and I'll do a sural, usually on the opposite side of the perineal sensory. And so that's sort of what I find is enough. I feel like that's enough for me to feel comfortable and confident in making the diagnosis. So I haven't counted that up lately, but that's 1, 2 sensories, 3 motors, and an 8. So that's 6 total nerves. And I think you can add to that if they have more more symptoms that are specific or for a potential other plague. You're thinking there may be a perineal neuropathy as well, fibular neuropathy. But I think that you can get away with something a lot less than what we've got listed here. And like I said, in the upper extremities, they did mention some numbness there, but I think I would be guided a lot by my physical examination in the upper extremities too. Sometimes they can have some vague numbness, and they don't have anything that suggests on their physical findings, no weakness. And I'm pretty detailed about how I look at that. I don't just grossly look at hand intrinsics. I very specifically do comparisons of side to side for first dorsal neurosseous, abductor digiti minimi for ulnar strength, and thenar, pure thenar abduction, putting them in a position of disadvantage so that I can feel the very mildest amount of weakness there. And the same with, I guess I'm getting back to it. If they really don't have much to go on a physical exam, then I'm a little less inclined, especially to do as much as what this person did in the upper extremities. I might do a couple. I mean, I actually like the numb thumb. I think that's a good way of screening. Everybody has their favorite, but you can do one, and if it's abnormal, you can add to it by doing a few more. But if they have a little bit of numbness that is vague, they don't have very impressive physical findings. I do a study or two, and it's all normal. I could stop there. You don't have to end up with all of this, including the medial and lateral antebrachial.
Right. Yeah. No, I think those are great points. And I saw a couple questions. Why if a patient has exactly the same symptoms on both feet, why do you do a superficial fibular on one and then you do the sur on the opposite? I'm just curious. Does that matter, or could you just do it all, just do one leg? It's convenient. You're not switching late side to side. You know the other side symptomatically is the same, or is there a
I like
rationale for
I
that?
like to do both. I know it's sort of, I mean, you heard my rationale, and that is if it's generalized, I want to prove that it's generalized. In the same way, I will often do both lower extremities with some EMG. I'll do, especially if there's a radicular thought too. I mean, I'm definitely going to do it then. But even from a generalized neuropathy standpoint, there are certain things that not only help me confirm, but they help me grade the severity of the neuropathy, and also can speak to me about the progression. You know, we all know that if something comes on more quickly over a shorter period of time, we're more prone to having, you know, positive waves and fibs, some denervation. And I look at first dorsal neurosseous, abductor hallucis brevis. I like those in the feet. And then also, you know, the way I look at the EMG in peripheral neuropathy, and this is what I teach my residents too, is there's sort of like a 3-tier. The first tier to be involved is the feet. You always have to be careful about, you know, shoe and boot trauma, the old Gatens and Said article. But that's the first tier. And then once you get a bit worse, you start to see it in the posterior calf, you know, soleus, gastroc. And then when it gets more severe, you start to see it in the anterolateral leg, anterior tib, extensor digit longus, peroneus longus. And so I like to do the EMG. And I said, like I said, sometimes I'll do some muscles on both sides
So
just because.
do you start? Sorry to interrupt you. Do you start in the foot for your needle
No,
EMG, or you start
no,
in like
I don't.
the
My you know, again, this is habit. People have their own habits, and I don't know why I ever started this way, but I do. In fact, I tend to do nerve conductions first and EMG second in the upper extremity, but in the lower extremity I do EMG first and nerve conduction second. Maybe because in the upper extremity are more common problems you're going to find with nerve conduction first, and in the lower extremity the radiculopathies and such, you know, you're going to find with the EMG first. But anyway, that's the way I learned. That's the way I've always done it, and I have an orderly progression. I have 3 muscles in the anterior lateral leg. I have 3 muscles in the posterior leg, and then I do the foot after that. The 3 muscles in the anterior lateral leg, I go from medial to lateral. You know, anterior tib, I do extensor digit longus, and I do peroneus longus. And then I do gastroc, soleus, and then a muscle I love is posterior tibialis. So you can call it flexor digit longus. It doesn't matter, but it is an L5 and it's tibial innervated, and it's fairly early. It's that second tier response to a generalized neuropathy. So I like that. And then the foot, like I said, first dorsal neurosseous. Sometimes I may not have to do that. If I go into first dorsal neurosseous and I see 2 to 3 plus positive waves and fibs, and I'm already starting to feel some connective tissue, I probably don't have to do the abductor hallucis brevis at that point.
Mhm.
And so, you know, again, it's just we do all of these things trying to sort of do the least amount we can, but to be as confident as we can in the diagnosis we're making. And so back to your original question about why I might go to the other leg. I mean, I think I might agree with somebody that says, well, you know, if their symptoms are the same and their physical findings, you know, vibratory loss, reflex loss, et cetera, are the same, do you really need to do both legs? And maybe I'm just appeasing my own, you know, self, but
Mhm.
I really do like to prove to myself
Right.
that yes, I do have abnormalities, objective abnormalities on my test, my nerve conduction, and maybe even the EMG as well in both legs, and that
Yeah.
helps for me to confirm the diagnosis.
Yeah, and I think those are great points. And we all know we all have different approaches, and not one approach is not correct, one approach is not incorrect. And I think the argument that I would counter with is if the symptoms and clinical findings are exactly the same, so not asymmetric weakness, if they're exactly the same, in my mind, I know and it's that story, starting in the toes, escalating up, and I know it's a neuropathy. And if I find, so in our lab, we would just do one leg and then go up to the
Okay.
arm, because I know, even if I do the other side and maybe the velocity on one side is 37, the other side is 35, there can be a little bit of variation, but I know this is the same process clinically. My level of suspicion for something else is is lower.
Gotcha.
But I think if there's asymmetry, and I think we would agree, I'm sure if, there's weakness on one foot, but not on the other, then there's asymmetry. We start to think of something else and we need comparison side to side. So
Sounds appropriate. Yeah.
let me ask you about the H reflex. We could
Uh-huh.
spend a lot of time on that, but let me,
Yeah. Yeah.
if the tibial motor conduction study is velocity is slowed,
Mhm.
just the routine between knee and ankle, what does the H add? You already have slowing of the conduction velocity. I know you're recording soleus and it's a different muscle, but does that help you more if you already have distal slowing in your routine conductions?
Well, that's a very good question, actually. And I what I'm going to have to think back on, or maybe even going forward, I may have to start looking at is how many patients have decent tibial conduction, but have abnormalities of the H reflex enough that I would say I throw it in the pile of abnormals that help me with the diagnosis, making the diagnosis, versus how many of them have some component of tibial slowing, and therefore we really can't count the H reflexes, being involved, especially because, long loop H reflex, it goes over such a long distance that there's lots of potential areas of concern, and that could give you that same prolonged latency or absent response sort of finding. So I think it's a good point that you make, Devin. And maybe I'll have to just get back to you when I've
No, that's okay. You know, you want to know
for
how
next year
many,
or something.
you want to know how many times I do an H reflex? I,
Probably not
I
much,
I do it about 2 times a year.
really.
This might be controversial, but I do it one to teach the residents and fellow how to do it.
Right.
That's time one. And then I usually do it once when I see a patient who has a classic S1 radiculopathy symptoms. They're sensory only, their pain or
Yeah.
numbness, and the
Right.
routine conductions and needle exam is normal. Then I'll do it. And most of the time, I still don't find the slowing there. So
Oh,
I don't
really?
know.
See,
I think the sensitivity for root is low, I think.
interesting. And see, I would almost say that I would almost say, and maybe this is being just to counter you a little more boldly, I would almost say that I have trouble diagnosing an S1 radiculopathy if I don't have some abnormality of the H reflex on that side. Now, I don't just compare side to side. I do compare side to side using 1 millisecond as my break off point. But I also utilize Bradham's original diagram. You can do it in a numerical formula, but I've never taken the time to memorize that. But when you put in age and leg length, you come up with what they should be.
Mhm.
And you can even take two standard deviations from that and then say, okay, that's the outside that they should potentially be. And so I have found that, I mean, remember, I trained under Ernie Johnson and Randy Bradham, who did some of the original work on that. Is a good buddy of mine, and so and I did a lot of training under a guy, you might have met him before he sort of left the organization, Dave Weekers. Who Dave is he was just an amazing neurophysiologist and thinker. He trained with Stallberg in Sweden for a year or two, and it was one of the things that he taught me about the H reflex is that you can use it for more than S1.
Mhm.
And so it's interesting how we get our training and we get used to what we do. But
Yeah.
I tend to do in every back patient that I'm thinking radiculopathy or generalized neuropathy, which tends to be most of them,
Mhm.
I end up doing H's.
Yeah.
And
And
I
I
do
think that
add
I
some.
and I think the point is that, like I said, I don't think with what either of us are saying is right or wrong. I think it's what we're comfortable with, what we're if you're experienced like you are in doing H's and identifying subtle abnormalities, um, I think that there's utility in doing that. So
Yeah.
I think it's just different approaches and they're both right. So yeah. So
Good.
interesting. Well, so let me show you what we actually did, the not this
Okay.
table, but what we did here, it's not much different. But I did, before I show you that, I did want to say, I asked you if there's any guidelines on how much should be done. And just for you probably were involved in this, I imagine maybe,
I
but
wasn't initially.
yeah, okay, but this is from the AANEM website, and I think this is a useful practice guidance kind of that summarizes sort of upper limit of test, the number of tests by nerve conductions and needle that would be used in most patients sent for a specific problem, right? So
Correct.
90% of patients for radiculopathy, you need less than 7 conduction studies. And this is the upper limit, and I would say probably a lot of us don't do as many if we don't need all of these. But I think this
Correct.
is a guidance, and for the neuropathy, it's a little bit harder because in the consensus statement they grouped mononeuropathy multiplex, which is, as you know, much more complex than a very distal polyneuropathy. But the guidelines was up to 10 conductions there. So 22 that I showed you, the fake EMG, is probably too much.
Yeah.
But 10, and they talk about, and this is from their text, that kind of what they think is reasonable to do, which is kind of what we both do.
Right. Now, what I will tell you, just to give you what the fraudsters say to this, because this comes up in every court case that I do, and you can find it both in the suggested guidelines for electrodiagnostic and proper performance of electrodiagnostic medicine. And as you said, and those are two of our position papers, and as you said, it's also reproduced on the website. And interestingly, it's also reproduced, the whole form. We have just part of it here, but the whole chart is reproduced in literally every insurance policies, reimbursement policies, every insurer, and that includes Medicare. So I mean, this is the standard that everybody goes by. But what I will tell you that the fraudsters say is, we had numbness in the arms. I was thinking carpal tunnel. So if you look at bilateral carpal tunnel, that's 10. And I had numbness in the feet, so we did 10. So that's 20. So they might only get 2 kicked out, even if they did as many as you did, which again, we both agreed that was too many. But that's sort of the way they look at it. But
Yeah.
I agree with you, and I think that the 10 is well within the limits of what you should be able to routinely get your diagnosis based on that amount or less of studies. Yeah.
Yeah. And I think in many patients, we do fewer. If we do, for us, and I'll show you what for us, well, I'll just show you here. So, um, well, let me ask you before I show you this. If you saw this outside EMG report, even if this was an outside study, the first one I showed you, even if it didn't have 22 nerves, it just had, let's see, 3. Is the table enough, or are the waveforms important to look at?
Oh, I always like the waveforms. And I mean, and then you're asking me that question based on whether, if I'm doing a fraud case, I always want to see the waveforms. You
Mhm.
can't imagine how much interference and 60 cycle and, poor conduction and a large stimulus artifact and, motor artifact, tainting all the sensory stuff. I mean, it's really important to see it when it's a fraud case. If it's just an outside study and I'm seeing the patient now, and I know the person, which I know most of them in my region, I'm probably okay with the numbers. But actually, I would always rather see the
Yeah.
full waveform. There's a lot of information that the numbers just don't tell us, and waveforms do.
Right. Yeah.
Even just simply where they place the markers. I mean, they
Right.
could place the markers wrong on a good waveform and be off because of that.
Yeah. Yeah. So, okay. Yeah, I agree. Yeah, I always like to see them too. And it tells you not only is there artifact, but is a technically reliable study, right? If make sure there's not a big positive initial positivity, and it
Right.
tells you, yeah, all those things. All right. So just to show you on this patient, so we just did one side. This is the fibular motor and the tibial motor, and the velocities were the same as in the table. So for our lab, they were a little bit slowed.
Mhm.
But for our reference values, the amplitudes were okay. So just the slowed conduction velocities in those two.
Okay.
And we did have temperature here too. So that's always
Important.
important, right? Yeah.
Now,
Uh,
Quick question. I mean, one of the things that I start to notice, I don't think it's severely involved, but I'm wondering if the proximal stimulation of the tibial, we're starting to see some spreading out of that waveform, a little bit of temporal dispersion, or are we going to say that that's, sort of normal for a proximal stimulation? Because I can't see the numbers very well. Does it drop in amplitude at all?
It doesn't drop in amplitude. It goes from 7.0 to 6.3. The duration
Okay.
goes from 6.4 to 8. So not,
Yeah, it's not real impressive. Okay. Okay.
yeah, yeah. But you're
It just
right.
seemed that
That's
made me
where,
think of that.
and that's where looking at the waveforms, it has this little bump in it, which is a little bit unusual, but it doesn't, I would say it doesn't have dispersion with an
Okay.
abnormal increase in duration. Yeah.
Gotcha.
So, and then we did a Searle. So, for us, remember, this is 58-year-old. So for us, the amplitude here is 4. This is our B point. Do you do 3 points on your Searle or just 1 point stimulation?
I do 14. At times I will do 7, 14, and 21 centimeters. Is that what you do
Yeah.
there?
Yeah. So
Yeah.
7, 14, 21. So
Yeah.
for us, for our lab, 4 at his age would be a little bit low, and the
Yeah.
conduction velocity of 35
Okay.
would be a little slow.
Yeah. Yeah. I agree. Obviously, I have to do at least 2 if I'm going to do a nerve conduction, which I don't always do. Often I'm okay with just the latency and especially the amplitude, because like we both said before, most of the time they're axonal and we're looking for loss of amplitude. And if I'm already seeing that, then I may not go and do the 21 or the 7 to go with my standard 14 to get a nerve conduction. But I agree with everything you said about this one. Yeah.
Yeah. So, and then I agree with what you said about going up to the arm. If someone, for us, if they have abnormal conduction studies and they have symptoms in the hands, if the leg's abnormal, we will go up and we'll at least do start with a sensory in the hand because it's just sensory symptoms.
Right.
Usually, and this is sort of our approach, we start with the median sensory, the antidromic.
Okay.
That's our first one on the upper limb in the more general neuropathy. And this is what we obtained here. So the distal latency was prolonged at 4.7. In
Mhm.
our lab, that should be less than 3.6. And then the
Right.
amplitude's low and velocity is a little bit slowed.
Right. And I agree with everything you said. When I go up and do, like I said, I do the numb thumb. So I'm doing median to digit 1. You're doing it to digit 2. But everything else you said there, I totally agree with. As far as we're seeing some subtle abnormalities of amplitude, of latency, and even the conduction. Yeah.
And then the thing that our techs will often struggle with is they get this and they say, okay, how much do I need to keep going in the arm? So we know it looks like neuropathy. Is this, as you said, could they have carpal tunnel? There's a median neuropathy at the wrist. So do we have to investigate that or do we just assume this is from the neuropathy? Well, what would you do? So because the
Well,
latency is long here and you can get that with neuropathy, but
right, right. Well, I think if we're going to truly localize it at the carpal tunnel area, you need to get some sort of a conduction across the carpal tunnel instead of just looking at some latencies, which can be prolonged because of low focal entrapment or can be prolonged because of some generalized nerve problem from like a neuropathy. So, I think doing something directly across the carpal canal would be helpful. In fact, the old Mayo Clinic study, comparing through the carpal tunnel would be a good one there.
Mhm.
Um, I think that even comparing, though we can say you're not truly going isolating to the carpal canal, but as you start to do comparisons, median and radial to the thumb, median and ulnar to the ring, median motor versus ulnar motor, when you start doing these comparisons and you use appropriate values for what the cutoff is, and you have a number of them that are abnormal, that begins to be a pretty good case for a localized involvement. But really, the purest way would be to isolate to the carpal canal itself,
So
uh,
yeah,
and then you can differentiate
so
between
you
carpal tunnel, which is localized, and generalized neuropathy, which is more diffuse.
yeah. So you were with the comparisons, you're talking about things like the combined sensory index.
Well, I think that that's Larry Robinson's overall sort of way. I maybe I'm not totally sold on doing all of that many every time.
Mm. Yeah.
And I'm not calling Larry a fraud. He's a good friend, and I trust him implicitly. And I understand his method and the statistical analysis that goes along with it. But I do, the way I look at carpal tunnel, and we may be getting a little bit off course, but just quickly, so to summarize what I do for carpal tunnel when I get to the point, I mean, history and physical are got to guide what we do and set up what we do. But if we're thinking carpal tunnel, I do like median and radial to the thumb at 10 centimeters. I do like median and ulnar to the ring, and then the median and ulnar motor comparison. Of those three, I feel like two need to be abnormal, not just one. I think that we're going to be too sensitive there. So
Mhm.
two of those need to be abnormal. 0.4 difference to the thumb, 0.5 difference to the ring, and a full millisecond difference through to median and ulnar motor. And again, if there's two out of those three that are abnormal, I'm feeling pretty comfortable with calling it a carpal tunnel.
Okay.
Yeah.
And speaking of CSI, you know how many times I do a CSI a year?
One, to show
Same
the
as I
resident.
do H reflexes to teach the residents in the rare case that I think a patient has carpal tunnel and I don't find it on our standard comparison. So, so anyway, in this patient, what we would do is we would just do like an ulnar sensory, which we did here. And the ulnar antidromic latency, it's hard to see this, is 2.8. So it was well within
Gotcha.
our normal range. And so for me, if this was a more diffuse neuropathy, I would expect that distal
Exactly.
latency would be prolonged. And so
Yep.
here, then it gets into how much do we need to investigate it now? Is the median motor involved? And we would probably do that here.
Gotcha.
I don't have the waveform. We did an ulnar motor just to see is there subtle motor involvement from a general neuropathy, but that, then the techs, the struggle that they have is, we all have, is, okay, well, I find a median neuropathy at the wrist and neuropathy. Now, do I need to go to the other hand and see how bad the median neuropathy in the wrist is? And I always tell them, and I don't know what you think of this, is if they have symptoms in the hands, then yeah, we should see if it's on the other side. But if you find it incidentally because you're going up to the arm because you found neuropathy, and you find it incidentally and they have no symptoms in the hands, then I don't necessarily feel that we have to kind of investigate and do a whole bunch of conductions on the other arm. It's kind of
I
like,
would
do
agree
you
with
want to
that.
find it or do you not want to find it? And does it matter?
I would agree with that. And in fact, that brings in something that's interesting that you may have heard of, but we're putting together sort of a consensus group on identifying what is needed. What are the best ways to identify severity in carpal tunnel syndrome? Because we're all over the map on that. And, as you know, that is sort of what most people use. Whether you're saying mild, moderate, severe, or however you grade it, it's whatever grading system they're used to is what the surgeons end up deciding what needs surgery and doesn't. And so it's a pretty serious sort of business, right? And one of the things that in our I'm going to be a part of that group, but one of the things that it's already in the very early going, we haven't even had our first meeting, but in the emails that have been thrown around, I can tell you that there's going to be a significant component of symptoms involved. Now, we don't want to go so far that people can get surgery with symptoms only and never have an EDX study. But what you were mentioning was somebody that doesn't have symptoms. Do we really need to be chasing down something that we also have to think about the terminology? It's a carpal tunnel syndrome,
Right.
and syndrome is a constellation of signs and symptoms. And so I really feel like at that point, you've probably done enough. If they don't have symptoms on the other side, you've just diagnosed what looks to be a probably fairly mild carpal tunnel on the one side. I think
Yeah.
we're done for the day.
Right. Right. And then if they come back and, start having symptoms, you can always reinvestigate that. So, yeah.
Exactly.
Yeah. Well, good. So, and then I'm not going to show a slide, but the needle exam, you raised some really good points about how you approach a needle exam in a distal neuropathy. Our approach is kind of similar. What I usually do is I start with anterior tibialis and medial gastrocnemius. And if those if there's already abnormalities there, so fibrillations and large motor unit potentials, I don't necessarily go distal to the foot because I already have distal abnormalities.
I would
But
agree with that.
but if those are
Because in my
normal, that
three-tiered method, you've already got involvement of the second and maybe third
yeah,
tier.
yeah,
So it's going to be in fact, most of the time, by the time you get significant involvement, especially anterolateral leg, you're probably not going to find much but connective tissue in the
yeah,
first dorsal osseous
right,
anyway. So I
right.
would agree with you.
Yeah, but I agree completely with you. If those are normal, then it's useful to go more distal into the foot or in distal leg. And I think the other point that I'm not sure if you do this, but if the anterior tibialis and medial gastrocnemius are abnormal, I always examine proximal L5 and S1 muscles because I haven't
Definitely.
excluded that.
Yep. I
Yeah,
agree with you.
yeah,
Tensor fascia lata, yeah, or something like that.
yeah,
Gluteus medius. I mean, yeah.
yeah.
I think that you've got something that you're looking for generalized neuropathy, but all of a sudden you have something that fits with an L5. So you need to make sure that you say yes or no to that.
Right,
That
right.
that's good electrodiagnostic reasoning. I like it.
Yeah, good. So it sounds like we're in agreement that this patient and these findings with the real study we did would be consistent with a distal length-dependent, primarily axonal neuropathy involving sensory and motor fibers.
I
Yeah.
agree.
So last thing, because we could spend the next 2 hours. This is great. I love talking with you, but I want to get back to the fraud issue. So if you have a physician that you have seen or you've seen studies consistently and they're fraudulent or they're doing 22 nerve conductions in every patient, what in the past have you done? Do you for about with that specific physician, do you I see these and I think, do I get involved? Should I call this physician and say, what are you doing? And then have him be really upset with me? Or what would you suggest? Or what do you do when you're seeing this?
Yeah. Well, you're in a little different position, Devin, because you obviously being at the Mayo Clinic, you have a very strong referral base from all over the country, essentially, and I have a fairly strong referral base because of the geographic area that I'm in. My town is 100, not even 100,000, but I end up getting a catchment area of about 1 million. So I do have a large referral base. But what I've not had a physician that I saw the patient directly and had the notes in front of me where there was a severe abuse like that. I have a lot of cases like that I do from all over the country, right, with OIG and FBI and such. I have had, and so I'll bring this into the discussion, I have had a couple of instances that were fraudulent behaviors, not excessive numbers, but using handheld devices.
Mhm.
And, especially when they were being utilized in a way that a quick study and then they head right off to surgery, right? And that same company that does the studies in the arm and hand with the biometric glove that goes over and they shotgun, right? And I probably shouldn't name the company, but it's the only company out there that's doing it. That same company, if you look on their website, they have one for the lower extremities now. And it basically just looks at a sural. It's a little gun that looks at a sural nerve conduction. It doesn't even give you a good amplitude. It gives you a latency. And, they on their website say, well, you can identify neuropathies and you can follow them along. You can see them 6 times a year and do this study. Again, it's sort of all about the money. But I did have on 2 different occasions, I had a podiatrist and also an internist and the multi-specialty group he was in that were doing the handhelds. Each time I called them. And luckily both times they were very receptive.
Mhm.
The one was actually a good friend of mine from my church.
Mhm.
And so he trusted me outright. I ended up putting together a little bit of a letter that had some explanations, some bullet points. He shared it with his partners at their next meeting, and they quit using it altogether.
Mhm.
The other thing that I've seen was the mobile diagnostic labs. Now, of course, that's where a company will send out a technician and they will do 40 nerve conductions on a patient. They'll do 20 patients in a morning. All they do is go in and zap them all and then leave. There's no EMG involved unless they do a surface EMG, which they later bill for a needle EMG. And of course, we know how diagnostic a surface EMG is. Um, and then it's read later by a physician, and it's very expensive and it's quite abusive. They rarely, if ever, get the diagnosis right, and they're charging patients lots of money, and the appropriate care for that patient is kicked down the road, and there's all the other health care that they get studies and treatments they don't need based on the wrong diagnoses. But I've had one time a patient in my area, right in my town, was seen, and then I saw the patient. I looked at the study, and so I called the gentleman, the fellow physician, and I said, this is what this looks to be. And I told him, and in fact, the technician had come from Chicago, from Chicago to the West Coast. They got to be making a lot of money if they're
Right.
all over the country. And when I told him, I remember thinking in that one instance after I finished my short little spiel on the phone, I remembered thinking, he's either going to go off on me and he'll never talk to me and never send me a patient again, or he's going to tell me something like he did, which was, I thought it seemed a little weird, because basically they get approached by people that say, why send this down the street to Dr. Grant or Dr. Rubin? We can do it in your office, convenient for your patients. And by the
Right.
way, you'll make a little money doing it. And
Right.
so people that don't really understand think, well, this is a good deal. And so he said right away. And so he quit using them.
Yeah.
And that was that. So those are my instances of the fraud that I have seen locally and dealt with personally. I've not had one like the case that we were discussing where it was the number was just too many.
Yeah. Yeah. I think those are great stories and success stories. And, I always hope, and I don't like to ruffle feathers, so I don't usually call the physician. I have called sometimes and said, we obtained a different result. And, but yeah, it's hard. I mean, you feel bad for the patients. They're being charged all this money and not getting the correct diagnosis. But I've struggled with, well, do I bring this up to try to improve the quality? And I worry, like you said, that they'll go off and say, well, stop bothering me. I know what I'm doing and I'm going to keep doing it. And there is a bit of guidance, I think, on the website if someone wanted to report it. And again, you might have been involved in this, but this is from AANEM's website now. And if someone wanted to report fraud, there's some information. So
Perfect.
yeah. So well, I've taken plenty of your time. An hour's already gone by. It's amazing.
It is. I've
How
been having fun too, Devin.
yeah. And yeah, I think this is really educational. It's nice to go in kind of the different directions, talking about a variety of things. I always have found as I'm talking to people, not only through this, but at AANEM, that to know that it's interesting that we have different approaches. But the different approaches come to the same diagnosis. And like we said, it's not right or wrong. There's reasons for doing things. There's reasons for not. And it's just nice to hear different perspectives.
Yeah,
So
I agree.
well, I appreciate it. And I hope you have a great rest of the day, and looking forward to seeing you at an upcoming meeting or
Yep.
meeting. Yeah.
Well, I appreciate your time too, Devin. This was fun.
All right. Thanks, Peter.
All right. Take care.
Bye-bye. I hope you enjoyed that episode of Lessons from the Lab. It sure was full of quite a bit of information, some really interesting discussion with Peter Grant. I thought it was interesting. He didn't bite on my nerve conduction study table. I guess he thought that we always perform 22 nerve conduction studies on every patient. But no, I think really it's interesting because some people, as we discussed, do perform bilateral conduction studies, and there's nothing wrong with that. Some people perform more extensive studies in the arm, particularly if patients have hand symptoms, and there's nothing wrong with that either. So there are different approaches to try to get to the answer that we're trying to obtain when we see a patient with these type of symptoms. I always learn from Peter. I think it's interesting to get into the discussion of fraud and how much should be done and the quality of the studies. That's something that's important for all of us to think about when we're performing the studies and when we're viewing studies from people who have performed these elsewhere as well. So really a whirlwind through the world of electrodiagnosis. I hope you learned something. I hope you enjoyed the conversation, and I look forward to next time. Goodbye.